Alrighty. Thank you, Paul. And like he said, I'll be talking about the antimicrobial resistance to a lot of the agents that Kevin set me up for earlier with his talk, and then how we need some new antibiotics. So hang with me on some gloom and doom, and then we'll have some good news at the end. All right, so the first part of this talk, we'll talk about how C. diff is a multi-drug resistant organism, not only priority, but multi-drug resistant and also extensively drug resistant at times. And then we'll go into how does that resistance actually impact patient outcomes. And then lastly, like I said, we'll have end with some positive notes on rising C. diff treatment pipeline. So we'll start with some definitions really quick, but the Centers of Disease, CDC and European Center for Disease Control have definitions on what multi-drug resistant is, or MDR, as you'll see it on the slides. And so that's acquired non-susceptibility to at least one agent in 3 or more antibiotic categories. So not just 3 antibiotics, but they have to be different types. And then you have extensively drug resistant, or XDR, which is susceptibility of bacterial isolates to only 1 or 2 antimicrobial categories. And like I said earlier, Kevin set me up well because you saw this slide earlier with the different guidelines that have recommendations. But as he said, we only have 2 that are usually preferred. So when you're looking at the XDR definition, susceptibility of bacterial isolates to only 1 or 2, we already see that's an issue here because we only have 2 that are even preferred. And so unfortunately, resistance to these agents does exist, but I want to dive into how it impacts the patient outcomes because that's the center of what we're doing here. And so we'll start with metronidazole. So metronidazole is the nitramidazole antibiotic, and it comes in oral capsules and also intravenous or IV formulations. And resistance is not a new thing here. So first resistance reported in 2001, and this was followed shortly by the ribotype 027 outbreak, which was a hypervirulent strain and still an issue in clinical practice now. And so metronidazole but guidelines did remove metronidazole, as we saw in that previous figure, from preferred recommendations in 2017 for the IDSA guidelines, and then for the European ESCMID guidelines in 2021. So that's where Kevin showed that is if you don't have any options or access to vancomycin or fidaxomicin, that's when metronidazole usually comes into place. But resistance mechanisms that have been described in recent years include a plasmid-mediated mechanism and then also a heme-dependent NIMB, and it correlates with that fluoroquinolone resistance in that ribotype 027 outbreak that is very closely linked there. So how does it impact patient outcomes? So many papers have shown that compared to vancomycin, metronidazole is associated with worse patient outcomes. But this is one of the few papers that actually shows that it's associated with the susceptibility. And this is by one of my colleagues, Ann Gonzalez-Luna. And she looked into how the MIC, or minimum inhibitory concentration, or susceptibility, you'll see those interchangeably, impacts initial clinical failure. Her study had 356 clinical isolates with metronidazole susceptibility completed and used classification and regression tree, or CART analysis, so some fancy statistics, to show for predictive modeling, and found that with C. diff infection with an MIC of 1 or higher had about 2.5 times more likely to have clinical failure, which was defined as continued disease presentation and diarrhea. And this is actually 1 dilution lower than the UCAS breakpoint, so the European guidelines that have set what is resistant. So that's 2. And so this was even a little bit lower that was associated with those patient outcomes. But like I said, metronidazole has fallen out of favor, so we'll get into some of the preferred agents. So we'll look at vancomycin next. So vancomycin acts by inhibiting the cell wall synthesis in gram-positive bacteria, and it has been the workhorse for C. diff for a good while now. And so how it acts is it's going to bind to that cell wall terminal, diala, as you can see in the figure there, and make it to where it can't produce the cell wall. But mechanisms have been shown to change the cell wall in C. diff, with Van-G Opron being one that has had a lot of investigations and publications on, to decrease the vancomycin binding to C. diff. So there's more work going on trying to really iron out what is the exact mechanism of resistance, because we've seen some Van-G and some others, but either way, resistance is emerging. And also we want to see how often is vancomycin resistance out there. And so I think going through the literature, there's a lot of different surveillance studies that have different ways of testing for C. diff susceptibility, or just different regions. So it's hard to compare them all. But I think the MODIFY trial, which was a phase 3 trial that was looking at bezlotuximab that we've heard about in some of the other talks, and it was looking at they did a post hoc analysis to see how much resistance is there. And they found in 14.5% resistance to vancomycin, with a pretty good global representation. But I think it's a little bit covered up here on this slide, but this is between 2011 to 2015, so nearly 10 years ago. And so we know that vancomycin has been one of the preferred agents. It's been used a lot. And so this 14.5, although concerning, it's probably lower than we actually are seeing. And so how does this impact patient outcomes? So this was some of my work also with other speakers that you've seen, like Kevin Carey. But we were looking to see how does susceptibility impact patient outcomes, with 30-day sustained clinical response being our primary outcome. And so that's a composite of, one, we wanted you to have no diarrhea at the end of therapy. We want you to be alive at day 30. And then we also didn't want you to have a recurrence before day 30. So truly trying to get a true initial or sustained cure picture. And so to orient you to this graph, on the y-axis, that's going to be the percent of patients. The first two bars are going to be that sustained clinical response, that composite of all three, and then we break it down into each of those afterwards. Now the black is going to be your reduced susceptibility, and then the gray is going to be susceptible isolates. And so we had 300 samples or bacteria isolates from patients in the Houston area, and our overall resistance rate was about 33%. But when we look into what was really driving the patient outcome, so we see that it was 76% had sustained clinical response if you had a resistant isolate, versus 86% if you had a susceptible one. So that's a 10% difference that was statistically significant. And this was largely driven by the initial cure. So they were having treatment failure and having continued diarrhea after they finished their treatment with vancomycin. And these were all patients that had only been given vancomycin. And so you can see that that was also statistically significant there, and you had a lower amount or higher amount of less diarrhea in the patients that had susceptible. So it really does truly show that there was treatment failure, and that vancomycin resistance does impact patient outcomes. All right. Get to our last one from the guideline preferred agents is fidaxomicin. So fidaxomicin is a macrolide antibiotic that inhibits the RNA polymerase. And as we saw from previous, it's recommended above vancomycin in some of the guidelines because of it being narrow spectrum and having lower recurrence rates. And you can see this there at Cornley et al., published in 2012, and you can see that separation with the top line being fidaxomicin and that bottom one being vancomycin, and looking at the recurrence there. And so you can see you have recurrence a lot quicker with vancomycin. So that's what gave it the edge in some of the guidelines. There is unfortunately known molecular mechanisms of resistance, and this is going to be in that RNA polymerase, and those are denoted with single point mutations in RPOB or RPOC. Now, this is a systematic review that was completed by one of our graduate students in our lab, Tan Lee. And so she was looking at how often do we see these mutations. She looked at it in the lab to see, hey, where we were studying it, to see what was happening. But you can see in the box down here at the bottom, there's a lot that have been reported in clinical isolates and clinical practice as well. So we don't have a lot of prevalence, but it is there. And then this study was recently came out this year and is one of the only ones that have shown any kind of link to patient outcomes thus far. But this was a 3-year cohort study by Donsky's group, and they had aims of determining the frequency of infection with reduced fidaxomicin susceptibility and impact on the response to fidaxomicin treatment. And so of the 108 patients treated with fidaxomicin in this cohort, they had about 5.6 to 6% were resistant, so it is emerging. And then they had exploratory case series showing there may be a link to treatment failure and also as emergence of resistance on therapy. So more work looking here to see how we can help patients have better outcomes, but is looking like there is emerging resistance there that is impacting patients. All right, so we'll come back to this slide again. And so, like I said, we're going to do some gloom and doom at the beginning. But again, we were talking about how extensively drug resistant is going to be against different classes. Well, metronidazole, vancomycin, and fidaxomicin are all different classes. And so we're already seeing resistance to many of these. And to put some numbers to that, because I think that always speaks loudest, we have 245 clinical isolates from our surveillance studies here that have had susceptibility testing to metronidazole, vancomycin, and fidaxomicin. And so we're using UCAS definitions for whether it's a breakpoint or epidemiological cutoff, whatever is going to help define non-susceptibility. We found in the 245 that we tested, 22% were resistant to at least one agent, 9% to 2 of them, and 3% to all 3 being pan-resistant. Now, in that first part of the talk of metronidazole, I showed you that Ann Gonzalez-Luna, she found that if it was 1 or higher, that was impacting patient outcomes. So if we apply that definition, the numbers are even worse and more scary, in my opinion. 47, nearly 50% were resistant to at least 1, 28 were resistant to at least 2, and 9% were resistant to all 3 agents. So it goes without to say, we need some new C. diff targeted antibiotics desperately. And so, luckily, we do have some, as we've heard from Bob earlier about ibezapolstat, and Kevin mentioned a little bit earlier, and I think later we'll have one of the other agents. So I'll just give a quick brief overview, but these are 2 antibiotic agents that have completed phase 2 trials. And so ibezapolstat from Accurx, and then CRS-3123 from Crestone, which we'll hear from later. And it inhibits POLC-type DNA polymerase for this one, whereas this one inhibits methanol tRNA synthesis. So 2 different classes, which is also very exciting. Their phase 2 comparators were against vancomycin for both of them. And ibezapolstat was published this year, and we'll dive into those clinical outcomes. And then CRS-3123 has not been published yet, but positive results have been reported. We'll hear some more from those later. So I'll focus on ibezapolstat for the rest of my talk. Okay, and then so we already talked about this with the microbiome and pharmacomicrobiome, but this is looking at, on the left, vancomycin, and then on the right, ibezapolstat. And this is data from our phase 1 clinical trials for ibezapolstat. And you can see a lot of different changes and colors on the vancomycin where there's a lot less. So again, like we saw earlier, it's microbiome sparing and even has beneficial properties there. And then very timely, especially for the beginning of C. diff Awareness Month, this was just published, I think it was like November 6th by Whip Kloss's group. And it has even dove in further to explain why ibezapolstat is such a selective and microbiome sparing agent. So exciting new work coming out there. But as Kevin said, I was going to share a lot of the phase 2 results. So we had phase 2A and then phase 2B. So phase 2A was just a single arm of 10 C. diff patients that were given ibezapolstat, and we followed them over their treatment, getting different stool samples and doing microbiome assessment. But the good news is 10 out of 10 of those patients had clinical cure as well as sustained clinical responses. So it was very promising there, which triggered going into the phase 2B, which was ibezapolstat against oral vancomycin. So we had 2 arms and comparing there. And we'll go to the graph on the right. So kind of similar to the vancomycin one we looked at earlier, percent patients on the y-axis. And then we have clinical cure, which is to day right after, and then recurrence at day 30, and then sustained clinical response was at 30 days for that same definition. And you can see the clinical cure very similar between the 2 agents, but where we saw that microbiome sparing coming into anti-recurrence effects was at the 30-day, where vancomycin had 2 patients that did have recurrence where ibezapolstat had none. So promising findings from the phase 2 trials, and we're excited to keep going on and get hopefully some new agents in clinical use. So to summarize, C. diff is unfortunately multi-drug resistant and extensively drug resistant, with a growing number of these becoming more and more pan-resistant. And the resistance does impact patient outcomes, and that we need new agents. So CRS 3123 has promising reports, and we'll hear more later for that agent. But ibezapolstat had published great clinical results for their phase 2 and showing how it is such microbiome sparing and narrow spectrum. And with that, I will open it up to any questions or if we need to keep going. Thank you all.
Hey, Taryn, thank you so much for that presentation. That was really interesting. And, we are very excited to potentially have some new treatments coming down the line. Fidaxomicin was a great step forward. And if we can improve on that, that'll be even better. And also, I think in a time of antimicrobial resistance, it's really important to have multiple options. As a layperson who cares about antimicrobial resistance, I'm like, can we stop using Vanco because we use it for so many other things? You know what I'm saying? It's like it has so many other purposes, and it's like the more that we can get like these narrow things that just work on specific drugs, on specific bacteria, I'm like, then let's use those. Like, I could rhapsodize about that for quite some time. So we do have a couple of questions for you that we'll do. So Travis Carlson asks, how can those in drug development prepare for the inevitability of resistance to any antibiotic for C. difficile? Prospective epidemiological surveillance is important, but I think we need more mechanistic insight during development.
Yeah.
I feel like typical exposure to sub-MIC concentration isn't relevant since those agents are getting concentrations of 500 to 1,000 x MIC in vivo, and we know some forms of resistance are inducible. Travis, I barely understood that question, but good for you.
That was about the longest one in there, but yes. No, I think you nailed it. And that's what's so exciting about what Kevin and some of these studies were showing about pharmacomicrobiome, or just looking at the microbiome in earlier development so that we can know that it's sparing, so that we're not having this impact. But you nailed it. The surveillance is the biggest thing, and that's bacteria are smart, and their one goal is to live. So there's always going to be resistance, but having a pipeline that's active and making sure we're monitoring for it so that we can change clinical practice appropriately is going to be very important.
Yeah. And then we have a question from Jeffrey Lewis, who's asking, is there a role for combination therapy? Is there any way a clinician can test for resistance?
Yeah, so that's a good point. That's usually my soapbox that I get on for resistance testing in general. So the biggest problem with getting that information to the clinicians at the bedside is that it takes so long to isolate C. diff from the stool. So that can take usually 10 to 14 days to successfully get it isolated and pure so that we can test the susceptibility. And then that takes another 7 days. So it's difficile for difficult is what I like to say. I mean, it definitely does not make it easy to get that information. So there are you could send it to a reference laboratory or to like one of like ours, the academic laboratories that do testing. But by the time you get that result back, it's already done with therapy usually. So I think the best way to go forward would be to try to keep looking at those resistance mechanisms and maybe getting molecular tests that would be readily available to clinicians. But that's proven difficult, but we're working that way. But there's also strain typing that you can look into. So for that vancomycin paper, we did go back and look at what were risk factors of this, because we know you don't have that information at the bedside. And ribotype 027, the hypervirulent one, was always a signal, as well as a emerging one in the Texas area for sure is ribotype 255. And so looking at the strain types could also give you a probability of like, ooh, this could be resistant to some of my options, and making an educated decision that way. And as far as combination therapy, I haven't seen any looking into that, and that's interesting, especially when we were talking about the different drug classes. But then I still get a little nervous, especially when vanc and fidaxomicin are really the only combinations you could use right now, and thinking about the microbiome and trying to spare it for recurrence would be the issue there.
Yeah, and let's take one last question, then we're going to have to let you go. Melissa asks, is there any research being performed using bacteriophages to target C. diff?
Bacteriophages, yeah. So I actually do not have any knowledge of any ongoing studies at the time. I've heard it's very difficult to try to get that going. It'd be interesting. They're always a hot topic, but not to my knowledge right now.
Yeah, I haven't heard of anything as well. We'll have to see if anybody knows later on in the day, if they have some sort of secret project we're unaware of. Well, Taryn, thank you so much for giving this presentation. We really appreciate it. We look forward to seeing you again soon.
Thank you all.